The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
Nurses on the front lines of this pandemic say they are exhausted, burnt out, and desperate for backup, but they are as essential as ever. Tonight, how can internationally educated nurses help? Then, we'll do some myth-busting around mRNA vaccines and menstrual cycles. As well, what some family doctors in Ontario want you to know when facing COVID-19. It's Wednesday, February 2nd, and that's next on The Agenda. Nurses have been front and center throughout this pandemic, and for some time now, whether on social media or from organizations that represent nurses, one word keeps coming up: crisis. Last month, Ontario announced a pathway for more internationally educated nurses to qualify to work here. With us now for a closer look from the nation's capital, Amina Silva, an internationally educated nurse from Brazil who just became a registered nurse in Canada this year. In Markham, Ontario, Carla Ducusin, an internationally educated nurse from the Philippines who has also practiced in Jerusalem. She came to Canada through the caregiving pathway and has been working as a caregiver. And in the provincial capital, Birgit Umagba, an emergency room and intensive care unit registered nurse who is also a clinical practice instructor. Welcome to the program to you all.
Thank you very much.
All right, so Birgit, I'm going to start with you. You have been an advocate for nurses and a vocal advocate for nurses here in Ontario. I want to read an excerpt from an opinion piece you wrote for the Toronto Star titled, "Nursing Shortage, There is a Solution Right in Front of Us." This crisis didn't happen overnight. It was well underway when COVID-19 hit, and it won't go away when the pandemic ends. I'm furious that in the midst of this crisis, Ontario has thousands of IENs working as nannies, clerks, factory workers, and Uber drivers. As I mentioned, IENs, we mean internationally educated nurses. Birgit, there is a massive shortage of nurses in this province. The Ontario Nurses Association says 22,000, and that was before the pandemic started. Are you saying that internationally educated nurses are the solution here?
Yes, so internationally educated nurses are part of the solution to addressing the nursing shortage. Why do I say that? We have a lot of these nurses who are highly skilled professionals. They're qualified with lots of experience from different countries, their countries of origin, and some have actually worked in other countries in the global north before coming here to Canada. We have these nurses on ground. A lot of them have been trying for years to practice. They are part of the solution to addressing the nursing shortage. That being said, we have a poor working conditions right now. Nurses are quitting for a reason. So INs, yes, are part of the solution. However, if those conditions don't improve, INs will eventually quit as well. So we need to address the root causes while incorporating and bringing INs to work with us to hopefully transition into more permanent solutions.
Now, Birgit, as we know, the province recently made a decision to deploy internationally educated nurses in hospitals. Do we have an idea of how many IENs are on the front line or on the sidelines waiting to get onto the front lines?
So in terms of data, honestly, it's really hard to get a hold of the exact number of INs that are waiting to transition. I know recently our Registered Nurses Association of Ontario made a reference to over 15,000 INs that are waiting to transition into the workforce. There's a lot of people that would actually help solve, the crisis we are in right now. We have a lot of surgeries that are postponed, nurses that are breaking down just because of the shortage. So we really need accurate numbers to be able to address this, and actually to also see how many of these nurses, INs, have actually been able to transition. It's one thing to say, yes, there was an announcement made, but how many of these nurses have actually transitioned into practice? What I hear so far is there are actually INs that are still being deployed to work as personal support workers. They've been de-skilled. That's the exact terminology. So to work in areas outside of their specialties, and I think that is a disservice to nurses right now that are waiting and hoping that there'll be solutions to address the nursing shortage.
I want to come to Amina. Before I ask you your question, congratulations. I understand you recently became a registered nurse here in Canada, but of course, this is not the first time you've practiced. I'm curious, what was your journey to be a nurse like?
Yeah, so it was a long journey to become registered in Canada, and I was fortunate that I was able to ingress in my PhD program here. So that made the process a little bit easier for me, not in terms of validation, because the validation is still pretty much the same process, but at least I had more job opportunities because once you came to Canada and you are a nurse, but you're not registered, that doesn't count as anything because nobody wants to hire a nurse who is not registered with their council. So I started my process in 2019 and I finished a week ago or 2 weeks ago. So it was a long journey and frustrating with a lot of going back and forth with the council, trying to send documents and waiting for even a year to receive responses from them. So it was pretty much that.
Quite a long time, 2 years. I'm going to jump to Carla. You're also an internationally educated nurse, but you've been working as a caregiver. Tell us a little bit more about your experience in trying to become a registered nurse here in Canada.
Well, I came here in 2018 to work as a caregiver, and I started my nursing application in 2019 and I finished it last year. In fact, I am both licensed as an RPN and an RN. While it's quite hard working full-time as a caregiver, I did the examinations. I also did the language proficiency examinations, updated my safe practice. It was quite costly and it was quite hard because you have to balance your time between working and studying. And I was able to complete all of those last year. However, what's stopping me to practice is that I don't have the permanent residency application, permanent residency status, because my work permit is tied under the work permit of a caregiver. I am only allowed to work in the caregiving sector. So even if I am licensed, I cannot practice.
So that seems like a little bit of a trickier situation. Is there sort of a workaround in your situation with your permanent residence, or is it really waiting?
Right now, it's still waiting. I have submitted my application last year, and I haven't heard news yet. But the Registered Nurses Association of Ontario, led by Dr. Greenspan, is helping us. She was able to connect us with the immigration, and we are hoping for good news. I am a part of a group. It's not just me. Mm-hmm. I am a part of a group of 26 internationally educated nurses currently working as caregivers. And most of us are licensed, and we are just waiting for that one paper to start practicing.
What would it mean for you to finally get to practice nursing? You came here as a caregiver, but that wasn't really the goal.
Well, coming here as a caregiver for us was the fastest way to get into Canada. So we are like, wait, we can just wait it now and hopefully transition to become nurses. So it's quite different. But then we just wanted to put in the work and hoping that we start working as nurses.
Birgit, I want to come to you. You're also a clinical practice instructor. Can you give us a little snapshot behind the scenes of what it takes to get those qualifications for an international educated nurse?
It is quite a very long road. I have taught in the International Educated Nursing Program, and where nurses just like Carla come in, and they have to go through the College of Nurses, and they go through a credentialing process where they're evaluated on whether or not they need to go back to take some courses to be able to practice. And prior to that, they also have to write the NCLEX. So it's a very long process. And unfortunately, for many of these nurses, the process is quite unclear and very, very costly because, mind you, these are mostly parents that also have families, and they have families here and families back home to take care of. So it's quite a challenging process for them. So imagine someone like Carla, who was a nurse back home, was gracious enough to become a caregiver. Not to take away from what caregivers do. Every role is important, but I think she put in so much work, time, and resources to become a nurse, and only to be de-skilled in order to qualify to come here, and now to go through so many hurdles for years. So these are the realities of the very many students that I've actually taught. I've taught students who have more experience than I am. I'm not even kidding. I've taught students who are like 20 years older than I am, students who've had years of service practicing as nurses back home in different countries with different specialties, highly skilled, mature. These are the kinds of nurses we really need at the bedside. And I'm here teaching them, things they mostly already know, but they need to be able to just mark and check the papers. And obviously, yes, we're not saying lower standards. We're just saying make the process more transparent, seamless for these nurses so they can come here. The goal is to have nurses at the bedside. And I think other countries are doing this. I know the US is, and especially during the pandemic, they were able to make the process less rigorous, less confusing. And I actually had students who were in my program, they quit in the middle of it, wrote their NCLEX with the US, and they moved there. And the UK is doing the same thing. So I think in Canada, we have a long way to go. I don't understand the process myself, unfortunately. I can't tell you I do. And you can imagine the confusion amongst the students themselves. So yes, it's not clear.
I want to pick up on something you had mentioned. You had used the term de-skilled. What exactly do you mean by that?
Unfortunately, many times credentials from other countries that are, non-Canadian credentials are really looked down upon. This goes into, discriminatory practices and balls into colonialism and all that, and labeling, especially credentials from the global south as unfit or not enough, or people who are coming from educational backgrounds that don't have enough resources. So when they come here, they're overly scrutinized, and not to say that these people a lot of times are overqualified, and because I work with them, so it's not enough. Like, I actually have a first-hand experience with these students, so they're eventually de-skilled, like Carla, who is a nurse, a registered nurse, working as a caregiver. So let me ask every Canadian nurse out there how they will feel if they were to go to another country and be told that the only way they can transition to practice is to work in another area, like, for example, as a personal support worker. How would it feel for you? And to bring your credential, your Canadian credential, which you believe right now is so valuable and so highly esteemed, and then they tell you that it's not enough because we have a process. Yes, we have standards, we have to meet those standards, high quality care and education. However, I think a lot of this has to do with discrimination.
Amina, I see your head. You're nodding a lot, so I can assume that you are agreeing with Birgit a lot on this. I'm curious, obviously, you and Carla have firsthand experience. What are some of the barriers faced by internationally educated nurses when they get here?
I think, first of all, is the lack of clarity in the process. Once you send your credentials to be evaluated and you receive the report and send that to CNO, the response you receive, they are not clear how to address those gaps. So, for example, in my case, my biggest gap was the educational one, because my education was not evaluated equivalent to the Canadian one. And now, how do I do to fill those gaps? So they're not really clear limitations. They say it is your responsibility to find the program. And after you complete the program, they're going to evaluate if that is enough or not. So then I need to go there, find the program myself, complete the program, pay for that. So just after that, I can receive a response if that would be equivalent or not. And also another thing that I also think it is huge, it is the delays in the process. So as I said, I send different types of documentations to CNO to try to somehow address those gaps. And they had some response that took over a year to receive back. And then you receive those response and they did not accept that. So now you need to start everything from the scratch again. So I think it should be more clarity in the process for sure.
Carla, I want to get you in on this. It seems like you've done your due diligence. You've gone back, you've done all your tests, you've done everything. What are your thoughts in terms of the barriers there, for someone who's still waiting?
Well, the barriers, first and foremost, is it's very costly. For caregivers, there are 300 internationally educated nurses who are working as caregivers. So for them, some of them are helping out their families. So the salary that they receive should be divided between sending money to their families and also with the registration. So it's quite hard for them because every examination is expensive. You have to take the NCLEX, you have to take the IELTS, the documentations, you have to call your school for them to submit all the documentations needed by the people assessing with the College of Nurses of Ontario. It's quite hard. Another is that, like I said, you are working full time. Some of them are even working very long hours. They do not have enough time to study. So it's quite hard for people like me to balance the time between studying, between working on the documentation, between working as a caregiver.
I want to pull up a tweet that Birgit once tweeted. It's quite a powerful one, and it reads, "You know who isn't done with COVID? Nurses. We are tired of people who don't care about how their actions affect the vulnerable, immune-compromised, disabled, and marginalized amongst us. We are tired of being called heroes. We are so tired of everyone who's done with COVID." Hero. It's a bit of a triggering word. Why?
Why do we have to be called heroes? If not that they've made the working conditions so bad and they're shocked that we're able to thrive despite the poor working conditions. And not only that, like the same government that calls us heroes has put in a legislation to cap our wages. Like, what a slap in the face. Like, with the one hand, you say, hey, heroes, and with the other hand, well, you can bargain your pay. No matter the increase in workload, I do not care. You know what? I'm going to keep providing you hospital beds. I'm going to keep, trying to find you, non-qualified, non-nursing staff to come and assist you, despite being short. So yes, every time I hear that word heroes, I am triggered, and not just me, my colleagues are too, because the working conditions are so bad. I can't even tell you. They're horrible, horrible for nurses, like scary for patients, totally scary for patients. And I'm talking about dangerous working conditions. And here we are being called heroes. What a joke. Like, change policies, like repeal B124, the main reason nurses are quitting. Like, do something. Stop bringing us hospital beds when we don't have nurses to staff them. Like, I just don't want to hear that word heroes anymore, because we're not heroes. We're human beings. We're a lot of us are women. A lot of us are mothers going to work, trying to do our part in the best possible way. And we just need the resources to be able to work and save lives while not doing this at the expense of our own mental health. So enough of the hero calling.
Now, Amina, as we mentioned, you're now a registered nurse in Ontario. Do you have any concern going into the clinical settings at this moment during the pandemic?
Yes, I actually do, because I moved to Canada in 2017. So my last clinical job was in that year. So I just wonder, with all the shortage of nurses at hospital settings and any clinical settings are facing, how me as being so for that long period of time away from clinical settings, will the team have time to train me so I can have all the needed skills to provide appropriate care for those patients. How is going to be returned to a practice as a registered nurse in the middle of a pandemic in a province where there is a huge shortage of nurses. So all of those things come to my mind as well. So it is a little bit of excitement of finally being able to work as an RN, but also a little bit afraid of how the clinical studies are and how it's going to be this adaptation process to going back to clinics.
And Carla, has the pandemic shaped your decision in pursuing nursing, or you're dead set on becoming a registered nurse here in Canada?
Well, my mind is set to helping. My mind is set to serving and contributing. I see stories like what Bridget said, that nurses are exhausted and they really need IENs right now. And I really want to help. I want to share my expertise. I want to share my knowledge. And seeing them really burned out, calling for help, here we are. There's a lot of IENs waiting to start practicing as nurses.
Birgit, I want to ask you a question. Obviously, there is enthusiasm, there is passion, there is the need to help, but I want to play devil's advocate just a little bit. We heard some anecdotes and stories of young nurses, students, graduates who just went in, and some who you've probably taught, who get into a setting and maybe feel alone, don't have the supervisors, don't have the nurses that normally would be there to help them through some of that stuff. Is there fear that IENs would find themselves in a similar situation? Obviously, many have years of training, but, there might be a bit of a learning curve. Is that going to add perhaps chaos to the crisis that's already there?
Well, I'd like to think that is not going to add chaos, but it is true that a lot of nurses are worried that they don't have enough time to even care for the patient, let alone to train, nursing students or help IENs transitions. But that being said, that doesn't mean that there are not individual nurses out there that are waiting with open arms to support you and to help you transition into your role as a nurse. But it is difficult. These are difficult times. These times are actually unprecedented, like we've heard so many times. A lot, and why it's so difficult is because a lot of experienced nurses have actually left the bedside. So we have mostly new hires, new grads, training new hires and new grads, and which is a challenge, right? Nursing is a practice-based profession, so experience comes with practicing. So when experienced nurses are gone, so the newer nurses they have limited experience as well to share with you. So we're hopeful that more experienced nurses do not leave, especially with, hopefully, I'm quite hopeful that tomorrow's meeting with Premier Ford will definitely lead to a repeal of Bill 124, which is I really, really am hopeful for. Otherwise, that meeting to me will be completely useless. And the fact that I remember when this announcement was made that IENs will be able to transition into practicing right now, some nurses expressed their fears as to how is this going to look like, and some discriminatory fears that language barrier and all that. So I think it's very important that nurses keep their minds open, and those biases about IENs or a lot of these nurses not knowing how to communicate in proper English should really end, because these are all rooted in racist beliefs. These people, well educated, they go through such rigorous training and transitioning to be able to come here. So I want nurses to open up their hearts, their minds, to support IENs, because these are knowledgeable, highly skilled individuals that definitely know how to communicate and know how to critically think. Like the fact that someone knows English, is born into an English-speaking country, doesn't guarantee critical thinking. So I think people need to open their minds to receive other people that speak differently, that don't have the same, intonation as like they do, so we can all move together towards working as one profession. I really do hope that Bill 124 is repealed. Otherwise, even INs will burn out.
I want to actually pick up on Bill 124. You touched on a little bit about wage, but what else is holding nurses back? Why are they leaving because of Bill 124?
Well, our workload has increased in the past almost 3 years now since the pandemic. I remember, working in an ICU with 22 patients and having 20 nurses on a shift, 21. Sometimes, it's so bad we have 18. But these days, having 12 ICU nurses for 22 patients is the norm. So that means that every nurse has two critically ill patients, and the normal ratio is 1-to-1. Increased workloads. We're running in and out of these rooms. And don't forget, we're always in full PPE when we provide care. We wear N95 masks throughout our shifts. I'm talking about 12 hours shifts, 16-hour shifts. Sometimes people are being asked to stay for 20 hours. So our workload has quadrupled. You go home exhausted. I had to reduce my work hours. I'm mostly home these days because when I just think about the working conditions, I'm like, another day off. It's just too much to handle. So our workload has increased and we're not able to bargain. Thanks to Premier Ford, who implemented Bill 124 as soon as he got into office to cap our wages at 1% increase a year. We've all heard what inflation is like these days. So nurses are not able to afford childcare. Nurses are not able to afford houses. We know almost nobody can buy a house right now. And nurses are leaving because the workload is too much and there's absolutely no support. Even managers are leaving, let alone nurses. The work hours are inflexible. People, like I said before, a lot of nurses are women with children, with schools going on and off, online and in person. Nurses have had to take time off to stay with children. Childcare is very expensive if you have to go to work, and Ontario is still the only province in all of Canada that hasn't signed the $10 a day childcare deal. So there are a lot of inequitable policies working against nurses in particular because we're a female-dominated profession. So there's so many reasons, but Bill 124 is a major reason. Inflexible work hours, lack of support, sometimes from depending on where you work. That's also a major factor, and people are just tired, and the toll on the mental health is completely unbearable. I haven't seen these many deaths in my entire career, and it's a lot.
We are going to have to leave it there. I want to thank you all for joining us tonight on the program. Some very important stuff, some very impactful stuff. And of course, Carla, we wish you all the best as well in your journey.
Thank you.
And thank you so much.
Thank you so much.
Thank you.
Did the COVID-19 vaccine affect your menstrual cycle? It's a question many women asked each other quietly after they got vaccinated. It came up often enough that researchers took up the question. And what did they find? Let's ask from London, UK, Victoria Mail, who teaches reproductive immunology in the Department of Metabolism, Digestion and Reproduction at Imperial College London. Welcome.
Hello.
Thanks so much for being on the show. This is something that I think a lot of women have been talking about, and it's great to finally have some answers to these questions. So the National Institutes of Health, NIH, funded institutions to research possible links between COVID-19 vaccines and changes in menstrual cycles. What did they find?
So this was a really big and well-designed study that used data that was collected by an app called Natural Cycles that people are entering in real time to try and keep a track of their fertility. And it looked at data from 2,400 people who were vaccinated and compared that to data from almost 1,500 people who were not vaccinated and acted as a control group. And the study found that after the first dose of the COVID vaccine, there was no difference in the timing of the next period. But after the second dose, there was on average a little bit less than half a day's delay. But the people who saw the biggest change were people who had both doses in the same cycle, and they actually saw more than 2 days delay to their next period. But importantly, even these people who had more than a 2-day delay to their periods were back to normal within 2 cycles.
Do the changes only apply to people who received their dose during their cycle?
Well, everyone's always somewhere in their menstrual cycle, but no, it wasn't just people who had their vaccine during their actual period, the time during their bleeding. So it was really people, for example, if you had your period and then you managed to have both doses before the next period, these are the people who are most affected.
And did it matter which vaccine you were getting?
In this study, they only looked at Pfizer compared to Moderna. There weren't enough people who got Janssen to talk about that. But with Pfizer versus Moderna, it made no difference which vaccine you got.
I think for most women, depending on what's happening around you, if you're stressed, we've been in a pandemic for going on 3 years now. There's so many things that can happen that can change your cycle. Should people be concerned about the disruption in their cycle or the bleeding pattern?
I would say no. One of the things that this study also did was it looked specifically to see what percentage of people saw a change in their cycle of more than 8 days, which is the point at which we would start to say, oh, that's clinically significant. And although the average was way less than being clinically significant, a small percentage of people did see a change that was significant, but that was actually only a little bit more than those people who might have seen a change in the unvaccinated group. And I think this underlines for us just how much periods can vary naturally. As you say, they can vary because of stress, weight gain, weight loss, all sorts of things. And so these vaccine-mediated changes, they're quite small compared to the changes that we normally see, and nothing that I personally would worry about or that would stop me getting my vaccine. Indeed, I have had all 3 doses of my vaccine.
The changes that did occur, are they temporary?
Yes, that's right. The study specifically looked to find out if people had gone back to normal. And in this study, they found that people had gone back to normal. Even those who had a delay of more than 2 days had gone back to normal within 2 cycles.
Well, there's been a lot of conversations online about, people feeling a bit worried about taking a vaccine because of the impacts to fertility. So I wanted to switch our conversation to that. Is there an impact on fertility?
This study didn't look at that, but actually we already have a lot of evidence around the vaccines and fertility. So even in the clinical trials, the participants were asked not to become pregnant, but they were big trials and accidents happen. And so there were, across the 4 vaccines that we've approved in the UK, 65 accidental pregnancies. And those happened equally in the vaccinated and in the unvaccinated groups, which tell us that the vaccines aren't stopping people getting pregnant in a trial setting. Now that the vaccines have been more widely rolled out, we also have real-world data. So we have 5 studies from IVF settings, which show that if you're going for IVF, it makes no difference at all to the chance that the IVF will succeed, whether you're vaccinated or unvaccinated. And we also now have a really lovely study that followed more than 2,000 couples who were trying to conceive between December 2020 and September 2021. And this study also found that there was no difference in the chance of conception if the couples were vaccinated compared to if they weren't.
That's interesting because I think there's still, I guess, you said that the changes occurred, it was the periods were maybe like 2 days later. If you are trying to get pregnant, I found this out the hard way. There's only a few days in a month that you can get pregnant. So is that something that people should keep in mind? Or is that valid enough? Does that make it valid for people to be concerned?
Well, this study didn't look specifically at whether in the actual month that you get vaccinated, it's less likely that you'll get pregnant. What I will say from my own research is that I see an awful lot of people getting pregnant the same month that they get vaccinated. So it doesn't seem to be stopping people getting pregnant even in the same month. But if it is a concern to you that you might miss your fertile window, the advice, if you're being vaccinated, is the same as the advice to everyone else. Have sex, have fun, and have it often. And that is the best way to hit that window.
Well, what about men? Do we know if a COVID infection impacts sperm count or the quality of the sperm?
Yes, we do actually. So there's really mounting evidence that suggests that if you get COVID as a male, you'll see a reduction in sperm count and sperm quality, which lasts for about a couple of months. And this has been backed up by that same study of 2,000 couples who are trying to conceive that I mentioned, because this also looked at the effect of COVID. And in this study, if the female partner got COVID, it actually made no difference to the chance that the couple would become pregnant. But if the male partner caught COVID, then the couple were less likely to conceive for 60 days after he caught COVID.
What are some common myths circulating around fertility and vaccines?
Well, I think one of the reasons that people were concerned about this was because it was one of the very early pieces of misinformation that came out in December of 2020. And it was put about that the vaccine was similar enough to a protein on the placenta that the immune response, the antibodies that your body makes to protect you against COVID when we give you a vaccine, could attack the placenta and cause a reduction in fertility. But all the evidence that we have that I've spoken to you about just now obviously tells us that that's not actually happening, because it doesn't make a difference to fertility. Another one that people sometimes worry about is that there was a slight misinterpretation of a document that was submitted to the Japanese regulator by Pfizer, which looked at rats and mice. And people have interpreted that to mean that there's vaccine that gets to the ovaries. Actually, that's not really the case. But again, the fact that people are getting pregnant just as normal after the vaccine, and also some studies that have been done, particularly in IVF settings, looking at ovarian health and ovarian function after vaccination, tell us that in people, getting vaccinated doesn't do anything to your ovaries.
You know, I think once a myth is out there or misinformation is out there, it can be hard for people to feel comfortable, especially if you are trying to get pregnant. How would you suggest that public health combats the misinformation that's already out there around fertility and vaccines?
Yeah, this is a really tough question, actually, because I spend a lot of my time thinking about how we talk to those who are already pregnant about getting vaccinated, because that's really recommended, because we know that COVID can be dangerous in pregnancy and COVID vaccination can protect you against it. And for that group, you know, they're already seeing doctors and midwives. So we have that trusted medical professional who's having regular contact with them. For people worried about fertility, it's a lot harder. There's no, regular contact with healthcare because these people are just getting on with their lives. And this is why I think that we have to take this kind of discussion to social media, which is what I spend a lot of my time doing, and also to broadcast media like this. And I hope that, you and me having this chat today will maybe set some people's minds who've been worrying about this at rest.
I'd like to read a quote from your editorial, which was published on British Medical Journal. You wrote, one important lesson is that the effects of medical interventions on menstruation should not be an afterthought in future research. Clinical trials provide the ideal setting in which to differentiate between menstrual changes caused by interventions from those that occur anyway, but participants are unlikely to report changes to periods unless specifically asked. What did you mean by that?
Well, simply that we could, in the clinical trials, have said, to that subset of the trial participants who have periods, why don't you tell us if you noticed something different about your period? And the reason that that would have been such a powerful approach is because we had an unvaccinated control group who didn't know if they've been vaccinated or not. And so we almost certainly might have had something, and a Norwegian study has found something like this, where, up to 40% of people in a normal cycle will notice something that's a little bit different from the usual. And that's obviously not to do with the vaccine because they've not been vaccinated. In clinical trials, we could have said, 40% of people notice something if they're in the unvaccinated group, and maybe 42% of people notice something in the vaccinated group. That's a small change, but because we've got a really good control group, it's a real change. If we had asked in the trials, we would have known that more than a year ago. But because It wasn't asked as a question in the trials. And because most people don't volunteer information about their periods unless you specifically ask them for it, we've basically spent the last year playing catch up. And I just hope that in future clinical trials, this additional bit of information will be solicited so we don't end up in a situation again where we're playing catch up to find out if there's an effect of whatever the intervention is on the menstrual cycle.
I think there's a lot of frustration from women because it seems as if that was an afterthought. I think when we're told to get our vaccines, we get our vaccines, and then all of a sudden we notice something change to our bodies that we weren't advised would happen. Do you think that moving forward, it might be helpful for people who haven't been vaccinated or are considering getting vaccinated to say, your period might change if you do get the vaccine?
I think that there's now enough evidence from this US study that we've discussed in detail and also the Norwegian one, which I've kind of touched upon a bit, to tell people when they're getting vaccinated, you might see a change to your period. It will be small compared to the kind of variation you might see normally. So you are likely actually to not notice anything at all, but you might notice something. If you do, it's short-lived. And the reason that I think it's important to say this is because I speak to a lot of people who have noticed, big or long-lasting changes that have happened after they've had the vaccine. The evidence suggests that these are not vaccine-mediated changes. And what we would hate is for people to assume that a big or long-lasting change that they saw was just a vaccine side effect, when really they should be going to the doctor and getting that checked out because it's likely to be something else. So yeah, I think that we now have enough evidence to say it's a small change. It will go back to normal. If you notice a big change or one that doesn't go back to normal, you really need to get that checked out. It's not that likely to be a side effect of the vaccine.
In our last 30 seconds, some researchers have argued that there's a lack of understanding on how males and females react to vaccines differently. What's your take on that?
I don't think that's actually true. The trials, particularly for these vaccines, were really, really careful to make sure that there was a good balance between the sexes. And actually, the trials also made sure that there was a really good balance of ethnic groups that represented, in particular, the American population. And the trials did look separately at how people responded to the vaccine, depending on all these kinds of important demographic factors, and how well they were protected. So I wouldn't necessarily say that that's really the case, but I do definitely think that we should consider sex a bit more in the future in medical research.
Dr. Mayall, thank you so much for spending some time with us and helping us understand these complex topics. We really appreciate it. Thank you so much.
Are you confused about COVID? Some doctors in the Family and Community Medicine Department at the U of T think you might be, so they've put together a website to answer some of the questions you may have. The website is available at confusedaboutcovid.ca. And to learn more about it, we're joined by Dr. Danielle Martin, academic family physician and chair of the Department of Family and Community Medicine at the University of Toronto. And she joins us in her office at Women's College Hospital in the downtown core of Ontario's capital city. Dr. Martin, great to see you again. How are you managing?
Great to see you, Steve. Thanks. I'm managing pretty well, but it's been a busy time for me as for so many others across the healthcare system over these last many weeks. So
Absolutely.
We were happy to have a chance to play our part in trying to cut through some of the confusion out there.
Well, tell me, let's start there. Why did you think a website like this was necessary?
Well, this wave of COVID, more than any of the previous waves, this Omicron wave, is really playing out in the community. I'm sure that every single person watching today has either had a COVID infection or knows someone personally who's been infected with COVID during this last wave. And the information out there can be really confusing. And so what we're seeing in our offices as family doctors is just a lot of phone calls, messages, emails, people coming in trying to understand, should I be rapid testing or shouldn't I be rapid testing? Do I self-isolate for 5 days or 10 days? How do I self-isolate in my household? How do I know when I'm ready to come out of quarantine? How do I care for my child with COVID? All of these questions that as the infection numbers are so high in the community, we are being flooded with these questions in family medicine, which is, of course, what your family doctor is there for. But nevertheless, we felt it was important that we come forward as a discipline. And so we've partnered up with the Ontario College of Family Physicians, and we've put these resources out to answer some of those very common questions that we're seeing in our own practices. And we're pleased to say that these resources are also available on our website in French, and we have 5 more languages coming soon.
I guess before we actually show people the site, I was going to ask you whether you're surprised 2 years into this thing that people still have so many basic questions, but maybe the better question is, are you depressed about the fact that 2 years into this, people are still asking some of these most basic questions?
I have to say that in the process of writing these, we got confused more than once ourselves. Part of this is the guidance keeps changing, and that is understandable. As we learn more, as the pandemic shifts around us, the advice is different from day to day. And some of it is also relates to, we have never seen before over the course of the pandemic, this many people being infected at this rate, many of whom are previously vaccinated, but some of whom might not be. And so the advice really differs depending on your circumstance. And so, I'm depressed, I suppose, Steve, in the sense that we all wish we weren't having to still be dealing with these questions and able to move on. And certainly it's not how any of us imagined we would be spending our time as family doctors, this much of our effort going into immunization and management of COVID in our own practices. But nevertheless, I think that this information is helpful, and it certainly does feel necessary.
Well, let's take a look, shall we? I'm going to ask our director, Sheldon Osmond, if he would, to go on the website, confusedaboutcovid.ca. There we go. And let's scroll down, because that's sort of the title page. Then we get to a bunch of boxes with a bunch of very typical questions. Let's click on the one, I'm worried about the new variant. How do I keep safe during Omicron? And again, people can scroll down, and there you've got a lot of very useful information about what you can in fact do to stay safe during Omicron. Now, let me ask you this. People are getting information from all over the place. Why should they trust this information more than what they see somewhere else?
Well, this information is brought to you by the Family Doctors of Ontario. So if you trust your own family doctor or nurse practitioner, your own primary care provider, if you would trust the advice that you would get from them, that is who has put this information together. And we've done it using the best available evidence, drawing from public health guidance and provincial and national guidance, but also interpreting it, which is what we do in our offices every day. In family medicine, we try to take what can be pretty complicated guideline type advice and distill it down to what are the critical things that you need to know in your current life circumstance. And so we're not inventing this stuff. It's not new information. It's information that has been collated, pulled together, and synthesized in a way that we believe speaks to the questions that we hear from our own patients every day.
Okay, I don't have to tell you that people are mistrustful of a lot of people that they used to consider authorities on various things. But do you feel that family docs, during the course of the last 2 years, during this pandemic, still are basically trusted by their patients?
Absolutely. I suppose it would be better to ask the patients that, but I will say in my own practice as a family doctor, that this is when we can be most useful and helpful to our patients. We spent a lot of time in the earlier phases of this pandemic relying on assessment centers to carry out swabbing and testing, and mass immunization clinics to carry out immunization. And family doctors were participating in all of that work. We were all out there participating in outreach to shelters and immunization clinics in, strip malls, and doing what we could to participate. But we're now in a new phase. And in this phase, coming back to that relationship that you have with the person who is your navigator through your healthcare journey, which is your family doctor or your primary care provider, is really important. And I think that we, as we look to the post-pandemic healthcare system, rebuilding those relationships is going to be even more critical.
I am going to be so bold as to say that I bet one thing that does depress you and has depressed you during the course of the past 2 years is that many people, many of our friends, are just as happy to take medical advice from some quack on Facebook as they are from a family doctor that they've been going to for decades. In which case, what prospects do you think your website can have fighting so much mis and disinformation that's out there?
I mean, I don't think that we're here to go toe-to-toe with somebody and, posting stuff on Facebook from their mom's basement. Our job is to bring forward our own expertise and evidence and to rely on the relationships that we have with people over time. I will say, Steve, honestly, that we see so many people who bring into us what it is that they're reading to ask for help interpreting it, that I think it's not a question of trying to erase all of these other sources of information, but most people will trust the healthcare provider who knows them best to help them to interpret, what does this mean for me? And whether that's an article that you read in People magazine or whether it's a post that you read online, if you're not sure whether something is for real, that is exactly the role of your primary care provider, is to help you to sort through the mess of information out there and help you understand what's most relevant to you. Sometimes what you read on the internet might be based in fact, but we all know that sometimes it might not be.
Do you want to take us through maybe a bit of Internet 101 here and tell us what sources online, obviously you'd put your own new website in that category, what sources you consider to be trustworthy, and some sources, based on what people have brought into your office, they should just absolutely disregard and say, that is not appropriate, that is not reliable?
Well, the first thing that I always say to people who bring in internet research is, I'm glad that you're researching. I mean, we actually do want people to be informed, and we do want people to be taking charge and active participants in their own health. But Dr. Google is not always your friend, and understanding, the source of the information is critical. So if somebody posts something to a chat room or a social media source that you wonder if that is for real, the first thing to do is try to ascertain what is the source of the information. And often you can learn that by looking at the source of the website itself. So, a website that comes from a public health agency is probably to be, much more trustworthy as opposed to a website that, I like COVID.com or some kind of thing that someone's invented, for themselves. And one of the things that we see in websites that are propagating misinformation about whether it's COVID or anything else is that it is common to put the name of the disease into the URL itself to make it look more official. And so the other thing that is important to look at is, what is the funding source of that website? And so, you'll see the website that we've put up is clearly part of an extension of the university. It comes from the University of Toronto. That's our funding source, and the Ontario College of Family Physicians. But if the funding source isn't disclosed, or if the funding source is brought to you by the makers of a supplement that is then recommended on the site, then that should make you raise an eyebrow and wonder, am I getting objective information here? And of course, the bottom line is, if you're not sure, ask. That's why you've got a healthcare provider, is to help to guide you through that information.
Right. Okay, in our remaining moments here, let me take advantage of your being here, just to ask you a couple of questions about where things are at today. We know that there are a lot of people in hospitals across the province right now who have been vaccinated. And so I want to ask you whether you can still recommend, with as much vigor as maybe you could 6 or 12 months ago, that people get vaccinated in light of that reality.
Absolutely. And I have to tell you that the patients of mine who have ended up in hospital who are not vaccinated have been horrendously ill. So a hospitalization is not a hospitalization is not a hospitalization. Your chances of ending up in the ICU or dying are much, much, much higher if you are not vaccinated. And many of the people who find themselves in the hospital with COVID today who are vaccinated are not in hospital because they have COVID. They're in hospital for some other reason, and it happens to be discovered that they also have COVID, which is very different. And that's only because there's so much COVID-19 out there. So remembering that the vaccination does not guarantee that you will not get infected with COVID-19, but it does really significantly reduce the likelihood that you will end up life-threateningly sick with COVID-19. And that is ultimately what we care about. We care about protecting your long-term health and your life. And so I went out and got my booster as soon as it was available. I was giving vaccines in my clinic today. I recommend it with as much vigor, in fact, more, because I worry for the health of my and mental well-being of my patients, given how hard it is in our hospitals right now, Steve, how overworked our workforce is, how many nurses and physicians are sick themselves, the immense pressure that is being applied to our hospital system right now. I would not want to go into the hospital right now. I wouldn't want you or anyone else to go into the hospital right now. So we should all be doing everything we can to avoid getting sick and going to the hospital unless it is the safest place for us. And so anything that we can do to reduce our risk of hospitalization right now is good for us. And it's also, of course, good for the healthcare system.
And that's the last thing I'd like to get you to react to, because there was a fairly significant development in the healthcare system last week when the green light was given to resume some elective surgeries and diagnostic tests that have been put on hold for so long because the system had to pivot to taking care of COVID-19. What's your reaction to that development?
Oh, I hope that this is a sign that we are now beginning the long, slow journey through to a different kind of a healthcare system at the end of all of this. I mean, you know, we now do face a significant backlog of surgeries and procedures. I know in my own practice, you know, people who've been waiting very patiently to see a specialist who've only been able to get a virtual appointment or been waiting for an MRI or whatever it is that has had to be rescheduled. So we have our work cut out for us. And of course, not just in healthcare, but all over every sector of the economy. This recovery is going to take a lot of time and energy. And so I hope that we're finally at least in a place where we can begin to look to that work instead of the constant putting out of fires that we have all been experiencing in the healthcare system over the last couple of years.
Amen to that. Dr. Danielle Martin, we are always grateful for your appearances on our program. We'll remind people, confusedaboutcovid.ca is your latest contribution to the fight against COVID-19. Thanks for taking the time to spend with us tonight here on TVO.
Thanks, Steve.
That is the agenda for Wednesday, February 2nd, 2022. Canada's birth rate keeps falling. Tomorrow, we'll examine how COVID-19 factors into that. I'm Jay Jaganathan. Thanks for watching TVO and for joining us online at tvo.org. And Steve, we'll see you again tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.